Today we are going to begin with a new topic, that is psoriasis. Many of you must have heard the word at least. Some of you pronounce it differently, and some of you might have even seen the patients in OPD, in the wards, or among your relatives, acquaintances. So this is quite a common disease over here, and we see these patients very frequently in our day-to-day OPDs and frequent admissions in the ward also. So I hope and let's believe too that at the end of this lecture, you will be able to diagnose a patient of psoriasis. Yes, you must be able to diagnose a patient of psoriasis and at least know how to deal with that patient. You need not treat the patient, but at least you can refer the patient to dermatology OPD. Now, what is psoriasis? It is a chronic, that is, the disease goes a long way, it has a long course, inflammatory skin disease, that is, inflammation is taking place in which there are recurring reddish plaques, often covered with silvery scales, and mostly these are present on the extensor surfaces of the body, that is the knees, elbows, scalp, and trunk. They may be present elsewhere, and later in the stage, or sometimes even it begins with involvement of nails and joints. So basically, this is a disease of the skin, but in its long course, it might become a systemic one. It has many systemic implications as well, and at some place in its course, it might involve the joints and even the nails. So it is considered a non-curable, a chronic skin condition, that is long-term course is there, which is variable, and it might improve and worsen at times. That is waxing and waning. It has a relapsing and then remitting course. And it is not unusual for psoriasis to spontaneously clear and remain clear for years and stay in remission. And all of a sudden, it might recur at any time. And many people might note a worsening of their symptoms in the winter months. Well, there are other aggravating factors as well, which we will be discussing side by side. So it is a chronic inflammatory condition of the skin, which might become systemic at the end, and it is quite common. It's about the incidence is 2% of the world's, prevalence is 2% of the world's population. And among the Caucasians, it is more common. In USA, the prevalence may be as high as 4.6%. No gender discrimination, equally affects and males as well as the females, and it may occur at any age, right from infancy up to the 10th decade of life, with first sign of psoriasis occurring at the mean age of 27 years in females and 29 years in males. So it's quite common, even higher in whites, Caucasians, but even we see a lot of these people in OPD, in wards, even in day-to-day practice. Now, what actually causes psoriasis, we do not know. Exact causes unknown, we say idiopathic, primary, or whatever. But there are a combination of risk factors that may be genetic as well as environmental. Now, yes, it is common to be found in the members of the family. It might be present in siblings and offspring as well, and immune system is thought to play a major role. As I told you, it's inflammatory, so immune system comes into play and causes some inflammation. How? We'll see later. And among the genetic factors, if the onset is severe and early, and it is associated with HLA CW6, that is human leukocyte antigen CW6. Genetic factor is there, yes. Now, what are the environmental factors? First and foremost is trauma any kind of trauma like surgical, chemical, physical, or electrical. And one very interesting phenomena is present in this disease, which is also present in a few other diseases, that is known as the isomorphic phenomena or the Kabner's phenomena, in which psoriasis can occur at places of trauma. Yes, it's not present, suppose here on the hand or on the wrist, but because of some even simple scratch or abrasion or a linear trauma, it can lead to the appearance of this disease at those places where it was not present before. This is known as isomorphic phenomena or Kabner's phenomena. It is also present in certain other conditions like lichen planus, vitiligo, and certain viral conditions like warts and molluscum contagiosum. So this is interesting that trauma can aggravate, and you can even begin a new a disease at a new site where it wasn't present before. Then it is associated with certain infections, most commonly the streptococcal and HIV infection, that is with simple sore throat. It can be aggravated. How and which type we'll see later. Then there are certain drugs like antimalarials, NSAIDs. Then among the antihypertensive drugs, we have ACE inhibitors and beta blockers. And very important association is with corticosteroids. Many of these patients, which because of their stress and because of quality of life disturbance, they go to hakims and other quacks who prescribe steroids because they think that steroids is a remedy for every disease on earth. So with these corticosteroids, this disease can even aggravate and goes into unstable and more severe forms. Then sunlight. Now, sunlight has a dual effect. In certain conditions, we even treat the patients with light. In certain patients, it might aggravate. Then alcohol and smoking definitely aggravate the disease and psychological stress. So a patient having stress for his disease can even aggravate it more. So you have to reassure the patient. Now, for its pathogenesis, three mechanisms come into play. That is, these are the endpoints of immunological reactions taking place inside the body. That is, when the immune system comes into play, what happens? There is epidermal proliferation, there is changes, there are changes in the vascular system of the skin, and finally, accumulation of inflammatory cells that release certain cytokines and other agents that come into play, and finally we see what is the result. Now about the epidermal proliferation, what do we see? As you must have learned in your first lecture about the basic skin. Let's have questions at the end, and especially if it's not related to this lecture. Okay, so there is increased keratinocyte proliferation with loss of differentiation in the basal and suprabasal level of the epidermis because of increased cell turnover. As I told you, there is a process of keratinization that begins from the basal layer, basal germinal layer of the epidermis, and when there is differentiation of the cells into the spinous layer and the granular layer, and finally into outer stratum corneum, there is differentiation of cells. But in this case, this process of keratinization, which normally takes place about 28 to 30 days, it becomes very rapid. There is, in addition to this increased cell turnover, which takes about only 3 to 5 days, there is loss of differentiation in the basal and suprabasal layers, and this will give a picture of hyperkeratosis, that is thickening and this scaling at the outermost layer, that is at the level of stratum corneum. Here you can see that this is a normal skin, which total differentiation or turnover, cell total turnover takes about 30 days, that is 4 weeks to a month. It takes place in about 3 to 5 days and resulting in an extra layer of cells which become dead and appear as whitish silvery scales on the psoriasis plaques. Then what are the vascular changes? There are vertical capillary loops. As you know that these blood vessels is present in the dermis, they become dilated, elongated, and twisted. So there is increased blood supply. Angiogenesis is an important component of this process, and this is mediated by certain factors like epidermal keratinocytes, interleukin-8, transforming growth factor alpha, tumor necrosis factor alpha, endothelial cell stimulating angiogenesis factors, and so on. And finally, as a result of this blood supply, there is accumulation of inflammatory cells in the dermis. And among them, the T helper cells have an important role in development of plaque psoriasis. Initially, there is activation of the T cells, then they migrate into the skin and they secrete cytokines and initiate an immunologic cascade. Now, how does this all happen? Let me show you a small video. Here, you can see.
Red patches are the hallmarks of a common condition called psoriasis. It's a disease involving immune cells. This was discovered by chance when, in the late 1970s, scientists noticed that the immunosuppressive drug cyclosporin can improve the condition. Skin has three major tissue segments. The epidermis is composed largely of specialized cells called keratinocytes. These originate from a single layer of basal keratinocytes, which divide continuously and give rise to cells that migrate towards the skin surface. During this process, they progressively differentiate into corneocytes, which form a protective barrier. Below the epidermis is the dermis. Here, cells called fibroblasts secrete fibers that form a dense extracellular matrix. This layer also contains hair follicles, sweat glands, sebaceous glands, and blood capillaries, as well as lymphatic vessels. These are a major conduit for immune cells such as macrophages, dendritic cells.
أول أصلا من هون جينا أول خرج عن أول أصلا ده ما جاشم كيف شو اللي يقول لك
Drug cyclosporin can improve the condition. Skin has three major tissue segments. The epidermis is composed largely of specialized cells called keratinocytes. These originate from a single layer of basal keratinocytes, which divide continuously and give rise to cells that migrate towards the skin surface. During this process, they progressively differentiate into corneocytes, which form a protective barrier. Below the epidermis is the dermis. Here, cells called fibroblasts secrete fibers that form a dense extracellular matrix. This layer also contains hair follicles, sweat glands, sebaceous glands, and blood capillaries, as well as lymphatic vessels. These are a major conduit for immune cells such as macrophages, dendritic cells, and T cells. Dendritic cells can capture foreign antigen and present it to T cells. T cells are immune effector cells. They can broadly be divided into cytotoxic T cells, which directly kill infected cells, and T helper cells that play a key role in orchestrating overall immune responses. In many ways, the immune pathways that become activated in psoriasis are amplifications of the immune activity of normal skin. However, the trigger for this inflammatory disease is unknown. Current models propose that dendritic cells sense stressed keratinocytes and invading microorganisms and start to respond by producing signaling molecules known as cytokines. These activate T cells and other immune cells, which in turn produce their own cytokines. Those signals stimulate keratinocytes to proliferate and to secrete further mediators and create a vicious cycle of inflammatory responses. Overall, this results in an accumulation of immune cells and the formation of a thickened, inflamed epidermis. several biologic drugs have been developed to target inflammatory mediators in psoriasis. The most widely used agents for severe psoriasis dampen down the cytokine TNF-alpha. But that treatment doesn't work for everyone. Up to a third of patients ultimately do not respond. However, in the past decade, insights into T-cell biology have uncovered some promising new drug targets. Traditionally, T helper cells have been classified into two subsets: T helper 1 cells, which are pro-inflammatory, and T helper 2 cells, which are anti-inflammatory. However, the picture has become much more complicated with the identification of many other specific cells. Each subset can possess 17 cells of attractor 3. IL-12 induces the differentiation of T helper 1 cells, which produce the cytokines interferon gamma and TNF-alpha. IL-23, in turn, induces T helper 17 cells, which make IL-17 and other pro-inflammatory cytokines. Scientists are now developing a number of biologic drugs that are targeted at IL-17 and other elements of the IL-17 signaling cascade. Different isoforms of IL-17 and the IL-7 drugs which act systemically, and they might result in clinical trials. Many of these are also in development for other inflammatory diseases, including rheumatoid arthritis.
So this was briefly about the pathogenesis. I hope you enjoyed it. By looking at all these steps that we just discussed, that how this psoriasis actually occurs, how the immune system comes into play, and what are the different cytokines. Well, that is not at your level, but at least you can have a simple understanding. And because this is important, that the latest drugs that are being used in the world, and up to some extent in Pakistan too, they are actually targeting these cytokines. These are known as the biologicals, and these are very effective, having minimum side effects, and they are being used. So now next we come to the histopathology. If you remember the normal structure of the skin, in which there are 3 layers, that is the epidermis, dermis, and the subcutaneous layer, the changes occur in all the 3 layers, but it's more apparent and that is visible in the skin is in the epidermis. There are early changes as well as late changes. In the early epidermal changes, as I told you, there is hyperkeratosis because of the increased cell turnover and because of loss of differentiation. Because there is loss of differentiation, there is a disappearance of granular layer. Then there is parakeratosis, that is, the dead cells are retained at the top and are visible as scales until they're removed with medicine or otherwise. And there is epidermal hyperplasia with elongation of red ridges. These are the early changes. Then there are late changes. Again, there is parakeratosis and small microabscesses they form in the epidermis, and suprapapillary epidermal thinning and invasion of epidermis with the leukocytes. Leukocytes from the dermis, they invade even the epidermis. And what are the dermal changes? There is vasodilatation, elongated, tortuous, dilated vessels that go up to the top of these papillae, and there is papillary edema as well as leukocyte infiltration. Here you can see there are elongated, these red ridges. Okay. There is these are also known as papillary dermis, and there is thinning of this epidermis above these papillae, and there are dilated blood vessels seen over here. And this is important from clinical point of view, which we will discuss later. That is when we elicit the Osgood sign. That is, if you remove the scale from here, if you remove the scale over here, there are pinpoint bleeding sites. These are because of these dilated blood vessels and because there is thinning of the epidermis above these dilated blood vessels. So hyperkeratosis, parakeratosis, elongated red ridges, the dilatation of the blood vessels, and suprapapillary thinning of the epidermis. Then we classify the psoriasis clinically, that is on the basis of morphology, into different types. 5 main types, but other types as well, according to the site, according to the different involvement, but mainly these 5 types, which we will discuss one by one. These are the plaque type, the guttate psoriasis, the inverse psoriasis, the erythrodermic psoriasis, pustular psoriasis, and few other types. In addition to these, as I told you, that it can also cause inflammation of the joints, which is known as psoriatic arthritis. And there may also be involvement of the nails. Between 10 to 30% of all the people with psoriasis also have psoriatic arthritis. Now, the first and the most common form, as you might have seen these patients, this is known as psoriasis vulgaris or the plaque psoriasis. Now, you must have heard this word vulgaris too much. This is not related to vulgarity anyhow. Vulgaris means common, like acne vulgaris, lupus vulgaris, that is the commonest type of tuberculosis of the skin, and psoriasis vulgaris, and so on. This is the plaque type, in which you have sharply defined plaques with sharply defined edges. These are raised above the surrounding skin. These are salmon pink, rich red with bluish tint, and they have usually, when it's not treated, they usually have silvery white scales. And as I told you, the Auspitz sign is positive, that is appearance of punctate bleeding sites where psoriasis scales are scraped off, and there is epidermal thickening. Usually these plaques are present on the extensor surfaces of the body, and especially on the elbows, the knees, the scalp, and the trunk. Here you can see typical plaque with silverish white scales on the top. Now, Auspitz sign is the appearance of punctate bleeding. When you scrape up the top scale. Then we have another type that is known as guttate psoriasis. As I told you, that is, it is aggravated by different infections, especially in children when it's secondary to streptococcal sore throat. What happens that a person who is already having a stable plaque psoriasis suddenly has a shower of small lesions on the trunk and abdomen with little scaling. And these are very small lesions that are up to 2 to 3 millimeter to 1 centimeter in diameter, round to oval. And they're just like raindrops. And these are discrete lesions present on the trunk. Here you can see there is an acute onset and often preceded by streptococcal pharyngitis. So this was guttate psoriasis. First one was plaque psoriasis, the commonest form, or the psoriasis vulgaris. Then we have guttate psoriasis. Another picture showing guttate psoriasis, small discrete lesions present in the trunk and abdomen, which may or may not have these scales. Then we have inverse psoriasis. Inverse, as the name suggests, that usually it involves the extensor surfaces, normally the trunk, the scalp, the elbows, and the knees. But in certain patients, there is involvement that is present in the flexures, in the folds. And in here, we have bright red smooth. There is no scale, perhaps because of maceration or sweating. And these are found in the folds of the skin. Most commonly, it's under the breast, that it's a inframammary space, in the axillae, near the genitals, under the buttocks, or in abdominal folds. And these irritated, inflamed areas are aggravated by the sweat and skin rubbing together in the folds, that is, trauma is aggravating them. And there may be secondary candidiasis because of yeast overgrowth, and that may further trigger. See? With trauma, there is triggering, there is aggravation of the disease. So inverse psoriasis, there is involvement of the flexures, the folds, where there is maceration, there may be yeast overgrowth, and the scales might not be visible. see, you can see erythematous plaques in the axilla and lack of scaling because of moistness of the area. It is more common in obese, middle-aged subjects, and the edges are again well-defined, like in plaque psoriasis, and there might be fissuring at the depth of the fold. That is again because of rubbing and maceration. Here's inframammary area, the groin, and in the axilla. This is inverse psoriasis. Then another type is the pustular psoriasis. This pustular psoriasis, this is a typical form which may be localized as well as generalized. In localized pustular psoriasis, there is presence of pustules upon a psoriatic plaque, and sometimes these pustules, they may coalesce to form lakes of pus as well. And sometimes it may become generalized, which is usually uncommon, but it may be characterized by acute, subacute, or chronic eruption, and it is usually provoked by environmental factors. There may be infection. It is mostly aggravated by pregnancy. It may be there in patients with hypocalcemia and other metabolic disorders. If it's in pregnancy, there is symmetrical and grouped lesions appear, and mostly in the flexures, and it starts in the third trimester of pregnancy. And yes, it's an emergency. It might even complicate the pregnancy. And in very severe cases, especially when we have a very limited choice of treatment in pregnancy, the treatment of choice might be termination. Well, that is a very rare case, generalized pustular psoriasis of pregnancy. Complications can occur. There may be hypoalbuminemia, hypocalcemia, oligemia. There may be liver damage. Even DVT can occur. It is deep vessel thrombosis. And if untreated, the patient can die because of staphylococcal infection, polyarthritis, and malabsorption. These are very rare complications, although. Then, as you see that we are moving from simpler forms of psoriasis to more complex and severer forms. Initially, we discussed plaque psoriasis. Then if there is infection, they may lead to the formation of small shower-like, raindrop-like lesions, that is cutate psoriasis. And in obese and middle-aged patients, it can occur in the folds, that is inverse psoriasis. Then in certain metabolic conditions, and especially in pregnancy, there may be pustular psoriasis, and now the erythrodermic psoriasis, that is at some point due to in the course of the disease, it becomes unstable. When there are plaques, it's all right. Patient is getting treatment, and sometimes even with topical treatment is fine. Due to any metabolic derangement, or even with certain drugs, with environmental factors, with stress, with trauma, and with especially after taking steroids, and there is sudden withdrawal of steroids, these lesions, these patients, they can go into erythroderma. Erythroderma is when there is more than 90% of the skin involvement. It's diffuse, and it might involve almost whole of the skin. And it might lead to skin failure with all the consequences. That is all the loss of function. There is loss of all the functions of the skin, leading to very severe and serious systemic complications. Now in this patient, because the thermostatic function is gone, the patient is febrile. There is even severe itching. And it is also associated in patients with arthropathic psoriasis. It is usually precipitated by infections. The patient might be having hypocalcemia. Antimalarial drugs, as I told you, different drugs are aggravating it. Among them, two are very important, that is antimalarials and corticosteroids, especially when it's taken for some time and withdrawn suddenly, the patient might go into erythroderma. Here you can see most all of the skin is reddish. erythro, red, and derma pertaining to skin. There is widespread scaling. There is itching. The body is warm. Now, the loss of thermoregulatory function, the patient acquires the temperature of the environment. He might feel very cold. Sometimes he's having high-grade fever. There is increased blood supply to the skin that might lead to cardiac failure. There is increased, because all of the skin is denuded, there might be infections and there may be loss of water and so on, that all the functions of skin are lost, and that might lead to skin failure with very severe and brief complications, right? Then there are a few very rare types that are rupioid, elephantine, and ostraceous psoriasis. In rupioid, there are cone-shaped lesions. Here you can see cone-shaped lesions, rupioid psoriasis. Then in elephantine psoriasis, were very thick, large plaques on the back, limb, and hips. And then there may be oyster shell-like lesions in ostraceous psoriasis. The rarer forms of psoriasis, these are chronic palmoplantar psoriasis, in which the erythematous and scaly plaques studded with sterile pustules present mostly on the palms and soles. And there may be history of burning and discomfort, and it is associated with smoking. Here you can see the involvement of the sole. Again, the palms of both hands are involved, studded with sterile pustules. Again, the soles. Then in children, the juvenile form of psoriasis or the infantile form is there, and it is rare with male predominance. It was erythrodermic psoriasis type. The acute or subacute or chronic forms may be there, and symptoms are often present, and usually remission occurs. Then modification according to the site. There may be involvement of the scalp only. There are very thick plaques at the occipital area, or there may be multiple or discrete plaques of variable sizes all over the scalp. It's most common in children and young adults. However, alopecia, that is loss of hair, does not occur. Then we have again involvement of the occipital region. Here you can see plaques are visible. Sometimes these are not visible, and only the patient is knowing that he is having some problem with which is itching and scaling in the scalp. There may be nail involvement. It may be associated with all types of psoriasis. There may be pitting, grooves, and ridges. Even there may be discoloration here. Then psoriatic arthritis. It is an inflammatory arthritis with negative rheumatoid factor, and there are no rheumatoid nodules. Then, as I told you, that this disease is associated with many metabolic conditions like hyperlipidemia, hypertension, diabetes mellitus, metabolic syndrome, ischemic heart disease, obesity, of course, aggravates it, gout, and inflammatory bowel disease, and can lead to general complications with systemic implications like secondary infections, itching, alcoholism because of stress, and the disease itself, as well as the different modalities of treatment, can lead to nephritis and even renal or hepatic failure. Now, how do we diagnose a case of psoriasis? Mainly it is on clinical grounds, but for confirmation, you can take a biopsy anytime. And few lab findings may be hyperuricemia, low folate levels, and hypocalcemia. And yes, we also go for liver function tests and renal function tests, because if we have to start the treatment. Let's skip this. And then how do we manage psoriasis? Again, as I always tell you, that you have to treat the patient as a whole. So there are general measures. Then according to the severity and area involvement of the body, we can choose topical or systemic agents. And the latest treatments are the biological treatments. Now, as you must be knowing that this is a very, sometimes it becomes serious and severe, but it's a chronic disease and it does not get treatment that is remission that is for good. There is relapse always. So you have to reassure the patient and you have to offer emotional support. You have to give him knowledge, give the patient knowledge about the disease overall. That is, it is not contagious. That is, it cannot affect his health until sometime it gets systemic complications. If he gets treatment, he will be better, and he should not go to quacks or hakims, and he should avoid certain medication in this disease. He should avoid smoking, alcoholism, stress, and trauma, of course. And for that, he can have lifestyle modifications, and you can also give him cognitive behavioral therapy, because this is not a patient that who's come to you and you just give them medicine and send them away hoping that he's going to get better. No, it's a chronic disease. At the same time, you also have to give him some know-how of the different drugs that you are prescribing, what are their side effects and how they have to be applied. Now, frequently they have to be applied because this is not a disease of 2 or 3 days. So patients usually are very suffering, and you have, at least you should give them some condolence or some emotional support. Now, depending upon the area of involvement, we have divided into different modalities. Let's say if it is less than 10% of the body surface area involvement, we can offer them with different topical agents. Even simple reassurance and simple symptomatic treatment like antihistamines for itching, the patient feels all right, and that can take so many months or even years that the patient does not need any further therapy, avoiding, of course, all those conditions that may aggravate. If the area is between 10 to 30%, again, we do not go for systemic therapy, but we go for phototherapy, and again, remain confined to topical. But if it's more than 30% involvement, then we go for systemic treatment, which we have different agents. So we'll quickly go through the topical therapy. For topical treatments, again, the first and foremost choice is topical steroids, especially for plaque-type steroids, plaque-type psoriasis. And then we have other agents that are steroid-sparing agents with less side effects that are there with steroids. We can give them vitamin D derivatives, vitamin A derivatives, tacrolimus and pimecrolimus. Then certain keratolytic agents that are to prevent the excessive scaling present on the top. These are salicylic acid or lactic acid. Then older agents were coal tar and things like that. So we start with simple antihistamine for itching, and if the area is very small, we can give them topical steroids that can cause skin atrophy or hyperpigmentation. So we give them steroid-sparing agents like calcipotriene, that is vitamin E derivatives. We can give them vitamin A derivatives. We can give them keratolytic agents, and we can give them calcineurin inhibitors, that is tacrolimus and pimecrolimus, and they are better because they are steroid-sparing agents, as well as they do not have these typical side effects of steroids, because the patient has to use them for very long periods of time. And yes, we can even have combinations like vitamin D derivatives in combination with steroid, or even simple steroids that are diluted with plain Vaseline. Older therapies were tar, then topical corticosteroids, as I discussed, there are different forms, vitamin D analogs, vitamin A derivatives like tazarotene. Then another modality of treatment is phototherapy, in which we can give UVB as well as UVA, and we have units that are phototherapy units present in our ward, and you can visit anytime to see them. They can give at the same time, we can be emitting UVB light or UVA, depending upon their wavelengths. And this is a very essential treatment for steroids having more than 10%, that is between 10 to 30% body surface involvement. without any side effects that are there with the systemic agents. So we can keep the patients on topical with antihistamines, and we can call them for this phototherapy usually 2 to 3 times a week. Then UVA therapy can be combined with a chemical that is known as psoralen. So psoralen P and UVA, it is known as PUVA therapy, which is useful in severe psoriasis. And sometimes this may become the treatment of choice. So phototherapy is a very good choice for patients, but the only problem is that they have to visit the hospital 2 to 3 times a day. Yes, there are smaller phototherapy units that is handheld that the patients can buy. And for scalp psoriasis, we have even phototherapy comps available in the market. Yes, they're even available in our city, and we can prescribe them. And of course, there are contraindications for phototherapy. All those diseases that are aggravated by light, like SLE, porphyrias, multiple melanocytic nevi, and cataract formation, they should avoid these phototherapy. And side effects, there may be burns, even there is increased pigmentation and increased incidence of skin cancers like basal cell carcinoma and squamous cell carcinoma. Then among the systemic therapy, when it is more than 30% of the body area involved, and it's not getting any better with the topical, with antihistamines, or with the phototherapy even, then we go for systemic therapy, among which we have methotrexate and other systemic agents are again oral vitamin A derivatives like E-tretinoate. Then other immunosuppressants like cyclosporin, they used to be given to these patients, but they have quite a large number of side effects, so we try to avoid them usually. And among the latest, we have the biological agents which target specific cytokines that are being released by the T cells that are involved in the pathogenesis, as we saw in the video as well. I'll just give you different names. Those that are being used already, these are elifacept, etanercept, ifalizumab, infliximab, and we have newer agents also that we study in different journals. These are being used in the West. These are adalimumab, secukinumab. This is available in Pakistan as well as being used for affordable patients. Ustekinumab, ixekizumab. These are monoclonal antibodies basically that may be humanized or human or synthetic, and they target specific interleukins that are produced by the T helper cells. Then among the miscellaneous therapy, we have sulfasalazine, other immunosuppressants like azathioprine, mycophenolate mofetil, and tacrolimus or pimecrolimus. Now, about the prognosis. The Tate psoriasis carries the better prognosis, usually gets better when the infection is settled. Then erythrodermic and pustular forms, they have quite some appreciable morbidity and mortality. More morbidity with arthropathic, that is psoriatic arthritis. There have been reports of complete remission in many patients, and they may stay cured for years and years, but relapse is a rule. It does not disappear for good. So what is the impact on the quality of life? As I told you that this is a chronic disease and we think it cannot be cured. There is social stigma, there are cosmetic issues, and it can affect all aspects of the patient's quality of life, even in those who are having limited skin involvement, even in those who are having scalp involvement, which cannot be seen otherwise. But these patients, they are really suffering, and always remember to address not only the physical, but also the psychological aspects of their health as well, kindly. Because these patients, they may feel socially stigmatized, and they have usually high levels of stress. So you have to tell them to avoid stress because it's gonna even aggravate the disease. There is high incidence of depression and alcoholism in these patients. And even at certain places, they may have to struggle with their employment status. So at the end, what is the take-home message? It's a chronic, it sometimes involves other systems, so it's a multi-system disease predominantly involving the skin, but may involve the joints and nails. And about 1/3 of these patients, they may have first degree relatives, that is siblings or offspring. And different types of psoriasis we discussed on the basis of morphology. That is the most common, that is psoriasis vulgaris, or the plaque psoriasis, inverse, pustular psoriasis, erythrodermic psoriasis, inverse psoriasis. A detailed history should be taken in these patients, and we give for all the basal investigations, baseline investigations. Usually we diagnose these patients clinically, especially the plaque type psoriasis, and nail involvement is also there. So you have to check all the symptoms and signs of these patients, especially on each visit. You will ask for any kind of joint involvement. You will seek any changes in the nails, so that they can be addressed earlier in the disease. Usually, we prescribe only topical treatment in combination with antihistamines. Topical treatments, different types, can be given alone as well as in combination. And if there is increased area involvement, then we can go for phototherapy or systemic treatment. At the same time, you have to advise the patients not to you have to advise the patient to avoid all those aggravating factors that might aggravate the disease. Then oral steroids, especially oral steroids, they should never be used in psoriasis, and they should be told to avoid the Hakims and avoid all these medications like beta blockers, ACE inhibitors, antimalarials, and NSAIDs, which aggravate the disease. So a successful treatment plan should include patient education as well as provide awareness of the patient's experience. So are there any questions? I'm sorry, I took a bit longer. Any questions? All right, thank you very much. Remember the Sunnah of Friday, ghusl, wear best clothes, males can apply perfume, males have to go to Jummah prayer, and if females do have the facility, they can also go for Jummah prayer. And remember to read Surah Kahf. You can clip your nails and recite the Root Sharif as much as possible. Remember me in your prayers as well. And I hope we meet next week too. That is your last lecture. And all the best for today and tomorrow and for your life. Allah Hafiz. Assalamu alaikum.